Okay, so it looks like the joining is slowing down a little bit, although there's over 70 of you here, so we are super excited about that and glad to have you join us. My name is Sabra Inkner, and I'm an Associate Director for AMCHP, which is the Association of Maternal and Child Health Programs, and I am joined by my AMCHP colleagues, Justin and Brittany, who will be your lovely facilitators and hosts today throughout our session. So next slide, please. So just a little rundown, welcome and introductions, which we basically just did. We will have our presentation from our colleagues and partners in South Carolina about their work on birth defect surveillance and other MCH program partnerships towards referral to services for kiddos. And then really questions and peer sharing opportunity for folks. So we really are hoping to have a conversation here about where everybody is at. There's no one way or right way to do this work. And we know that from what we've heard from the landscape analysis that we did recently and feedback in general is that this is an area where it seems like everybody feels like they have room to grow. And so we are hoping to foster those conversations beginning today and then continuing on over the next few months. And then we will have, we're going to try out, because we are also trying new things, doing an evaluation little survey through the poll feature within Zoom at the end of the session. So we're hoping to maybe get a few more responses than we often do when we send out evaluations after sessions and 3 people filled them out. So we're hopeful to get a little more feedback than that by trying it this way, and we will see. Next slide. So we do want to acknowledge and thank CDC for supporting this activity and more broadly their commitment to this work. And I'm not just saying that because our technical monitors are on the call. We are really excited about being able to do this and share this with you and their investment in this. And then the other thing is as we move into our presentation from South Carolina, which we anticipate will be about 30 minutes, we hope that you will have some ideas and some thoughts and some questions. You are welcome to put those into the chat, but we know that folks are not always so eager to say things with their name attached to them. So we've also put a Jamboard together, which is a way where you can, it sort of acts like sticky notes. You can create a little note that does not have your name attached to it if there are other comments or questions that you would like to present to the group after South Carolina's presentation. So with the next slide, please. So we do want to welcome our 4 colleagues from South Carolina who are here. We have Dr. Michelle Meyer, Tara Carroll, Vanita Leadham, and Karen Revels. And with that, Justin is going to stop sharing the screen, and I think Dr. Meyer is going to take over with that, and we will go from there. And thanks again, everybody.
Oh dear. This is Michelle. Give me just a second because this is a different interface than the normal, and I am not seeing my presentation at all. Let me try something else. Here we go. I have a brand new computer in my office that we now know some things that needed to have been fixed when they put it in. So that's life. And what we have all learned from COVID is to extend grace to each other. So I believe, can you guys, are you seeing a presentation that is not yet in presenter mode, but
yes,
will be in a minute? Okay, perfect. I'm going to try to put it in presenter mode. If it does not,
you are good. Looks perfect.
Okay, great. Well, again, thank you all at AMCHP, and thank you to those in the audience whose names I will see soon once I get off of this. By the way, if somebody puts something into the chat that's incredibly important, please feel free to interrupt me or any of our other South Carolina colleagues. because we won't be able to see the chat as easily. So absolutely interrupt if needed. I'm Michelle Meyer, as was mentioned. I am the Director of Children's Health and Perinatal Services here at DHEC, which is the Department of Health and Environmental Control. And we're going to talk a little bit about coordination between birth defects and early hearing programs in our public health system. We will share our experience. Your mileage may vary. One thing I want to point out is that we have an opportunity at the end to interact with peers nationwide, share challenges and strategies about linking families to care. And while we're sharing this stuff, we're sharing what's worked for us. We also know what hasn't worked, and we want to know what you have done that's better than what we're trying to do. So we're all good. All right, a little bit about our organization, South Carolina Department of Health and Environmental Control. We are different than any other state health agency in the country because we are both centralized, which means that everybody in the county is an employee of the same agency as everybody in the central office. That really makes it wonderful for doing referrals and other sorts of things within various programs, because I don't have to get permission to send something to a public health nurse. She is part of the same agency I'm part of. But we're also health and environment in one organization. That may be changing. Legislatures, have ideas that are different than ours, but for 50 years we've been set up this way. And then we have our newborn screening programs, and you guys know this. Newborn screening is the blood spot screening that we all used to call the PKU. It's early hearing and it's cardiac screening. All those early things are now in the Bureau of Maternal and Child Health, as well as the birth defects program. The building you're seeing was built in 1822. My office is currently on the 3rd floor. I have a wonderful view of the front porch, but it was built as the lunatic asylum. And sometime when you have a lot of time, I will talk to you about how wonderful it is to work in a 200-year-old building that was built to house individuals with mental illnesses. But here's why we're here. We're going to talk a little bit about some of the work that we do in our birth defects and hearing programs. And you guys probably are similarly set up to what we have. We have an epidemiologic focus, so we're counting, and we also have some kind of either direct care or coordination of care or assistance with paying for care or getting people hooked up with systems of care. We have both of those things. So instead of protect and serve, I say we're here to count and serve. So our coordinative functions, most of what we manage, whether it's a newborn metabolic screening, the blood spot screening, or hearing, or birth defects, we manage these things through various referrals to sources and systems of care. And most of what we are doing is short-term follow-up. We are not set up right now to follow individuals through the life course, even for some longer-term illnesses. A little bit of difference with that is our Children and Youth with Special Health Care Needs program does do some longer term follow-up for some things, and we have we even provide assistance with some things like metabolic formulas, factor for hemophilia clients, and then we do referrals. Sometimes the most important referral for somebody with an abnormal screen or an abnormal ping or a suspected birth defect is a referral for additional testing, whether it's another screen, whether it's confirmatory testing, sometimes just to verify the diagnosis, because you certainly don't want to start acting on something until you're sure that that's what the child actually has. And we also work really hard in all of our programs, as do you guys, to try to get the primary care physician or either PCP or HCP, however you choose to spell it, and the families to get them connected with specialists, because many of the conditions that we screen for are things that are outside of the scope of our clinical expertise to work on. So we have a strong epidemiology focus because you can't serve the people you can't count. We have a strong referral focus and a strong partnership focus. What I gave you on this slide is a little logo from our legislative update. The legislature are also our partners, in addition to, say, early intervention or audiologists or specialists who work on congenital cardiac problems or other birth defects. Our legislators need to be our partners, and they need to know that they're playing on our team. So we make sure that they get good information and here's just a random screenshot from one of our recent reports where we have the number of people enrolled by a certain age and the number referred for early hearing or whatever. We try to share that information, and if your legislators don't know that they're part of your team, we need to work on that. Of course, if you're state employees, you know, we have all kinds of limitations on us being able to contact folks, but we do hope that they know things. I pulled from the March of Dimes, each year in South Carolina, and this is still accurate, it's about a year old, more than 57,000 babies are born. 1,700 of them may have a birth defect, and unfortunately 1 in 6 infant deaths is due to a birth defect. We just recently released some infant mortality numbers, and they are not where we wanted them to be, and unfortunately some of those fatalities are due to birth defects. So the other focus that we have, besides counting and getting people hooked up into partnerships, is really listening to our communities. And I picked a couple things from our first sound program, and Tara Carroll, who is our director, will be the last person speaking from our group. And these are affirmations or things that we shared in our legislative report. One's from a young lady who has 2 cochlear implants, is a middle schooler, and her dream is to play for the Gamecock women's basketball team. Yeah, we did pretty well this year and won the national 2 years or a year ago. But what a great goal. And a child with cochlear implants might never, ever have considered that kind of thing later at another point in her life. And the other affirmation is from a young man who began speech therapy and catching up, and he's more working on spoken communication and less on sign. But these are great things, and we share these with our legislators, again, to say we want to hear the voices of the community. You guys have all heard this, nothing about me without me. There's also, if you're not at the table, you're on the menu. But with this, we need to make sure that we, in all of our developing and building of partnerships and other things, that we are also talking with the individuals for whom we are providing care. So, in summary, we're from the government and we are here to help you. We have birth defects resource guides. We work really closely with our hearing. We try to coordinate the services that the lab provides and that our newborn screening follow-up provides. This first little kid, you can see the scar on his chest, obviously. Look at that smile and how beautiful and consistent and non-blue his coloring is. This kid has done well, probably because of the congenital cardiac anomaly screening that happened. So with that, I'm going to turn this over to the newly minted Dr. Vanita Leadham and Karen Revels in our birth defects program, and they're going to talk to you about some referrals, and you guys just let me know when you need me to switch to a new slide.
Thank you so much, Michelle. As she mentioned, I'm Vanita. I work with the birth defects program, and next slide, please. So, you know, we in birth defect surveillance for a long time utilized our data for epidemiologic purposes, also for other research. And we wanted to know more about what could we do to make a positive difference in public health with the work that we currently do. So I had a conversation with, many of you might know Kara Mai at CDC almost 10 years ago. And I asked her, you know, what would the perfect kind of system look like? At the time, we weren't allowed to do referrals for a number of reasons. And even though we had a law that would allow us to do it, more on that later, we couldn't do it at the time. So I did some research on the conditions that could be referred, talked to Kara, talked to others at CDC, and really thought more and talked to my team members about the data and how it represents lives impacted. Next slide, please. So, you know, we wanted to know how our data could make a difference. And we knew that kids with birth defects have co-occurring conditions, speech, vision, mobility, cognitive, neurodevelopmental issues, others. And we wanted to think more about, well, which kids could benefit from referrals and how old are the children at the time of referral? So early intervention in many places, I think most places, is 0 to 3. In South Carolina, our birth defect surveillance program collects data up to age 2, or for now it's greater ages for kids with heart defects, but for other defects, it's up to age 2. So, you know, kind of that ripe time to make a referral. Next slide, please. And, I needed buy-in. So like I mentioned, it actually wasn't allowable in the beginning. And, we'd been around since 2006 and it wasn't allowed. And so I spent several years actually trying to find out, well, what was the different types of pushback? What type of buy-in did we need? We needed OGC buy-in. So we needed legal to really get behind us. So, we had several meetings with people at BabyNet, with people here, but it really was like our own legal department that needed to give the first green light. So I'll share a little bit about our law and how we discussed it with them, what we got out of it, what we tried. I needed buy-in from stakeholders. So, I wanted to meet with early intervention and really say, if we do, a backlog of referrals, so everyone that through the age of 2.5 at this point in our system is referred to you, even if they might have been referred before, we don't necessarily know that. If we referred them to you, would you be able to handle it? And I wanted to know if our efforts were coordinated with other internal partners. So I talked to other partners in MCH and got support from them, people such as Dr. Meyer. We also wanted to know what kind of burden it would be on staff. So we had some very talented team members, or have some very talented team members who were willing to sort of explore this. And then what kind of cost would there be? Next slide, please. So this is our law. We actually have a really fantastic law, and it just shows, like, even with a great law, there can still be a hesitation to do things like this because you are sharing PHI with another organization. However, our law specifically spells out we are allowed to do public health monitoring and referrals. And if you look at the next slide, in addition to the law, there are also regulations that many states have attached to certain statutes. And ours actually specifically mentions doing referrals with family members identified. And we can go directly to the family or through a child's healthcare provider. Next slide, please. And then in addition to knowing how we could reach them, we knew specifically that we can contact BabyNet, which is the name of our Part C area, early intervention. And so it actually specifically says that our abstractors will conduct surveillance, review medical records of different kinds of medical records, and assess whether there was follow-up for referrals, and then do the referrals. Next slide, please. Next slide, please. Okay, thanks. So the advisory council as well, I like that picture. So they really were pivotal, I think, in making sure this happened. But when we met with the advisory council and we shared, we haven't been doing this, there was some hesitation and pushback, how should we do it? We actually created a strategic plan that was vetted by our team members as well as our advisory council, which the representation is comprised of physicians, public health and social entities, as well as people who have birth defects. And we actually built an activity into there that made it, not only is it legal to do it, now we want to do it, institutionalize it into our system to ensure that all qualifying infants are sent to BabyNet for follow-up. So all live-born babies that are under 2.5. Next slide, please. And I'll turn it over to my colleague, Karen, who led this effort. But I'll just mention really quickly before we move on to the next speaker that there was a lot of pushback across many different people that I talked with, not in South Carolina necessarily alone, but also nationally, who were concerned about doing referrals for families of all live-born babies who had a birth defect, because the concern was, well, these people, they could be really scared if they get contacted by BabyNet, and what if they get worried about their kid and, and there's really nothing wrong. Well, we made the decision to go ahead and refer every live-born baby because we don't know what the other extenuating circumstances are that might allow that child to receive early intervention. And it was really just going to be a call and a screening that would make them eligible for services. So I'll give it to Karen Revels from here, who is a seasoned nurse abstractor with our program and is the spearheaded this effort, the pilot, as well as the protocols that she developed subsequently after this.
Thank you, Vanita. South Carolina Birth Defects Program went back to 2017 to catch up on past cases for referrals to the BabyNet program, and we completed the old cases in December 2022. We referred thousands of cases and learned the BabyNet processes. Next slide. In the B system, which is the birth exchange engine where the abstractors input information about birth defect cases, we also document under the referral section that a case was made to BabyNet, yes or no, and if no, the reason why. Usually it's because of a deceased infant, and then we put the date that referral was made. We also note if the hospital made a referral to BabyNet as well. Even if the hospital made a referral to BabyNet, we also make another referral to BabyNet services because the child might fall through the cracks, get lost in the system, or the parents were overwhelmed at the beginning and turned BabyNet services down the first time, and now they might be more receptive to services as time has passed. Next slide. This is the online referral to BabyNet. It is the first page, which is the demographics section. This information is already collected by the South Carolina Birth Defects program. Everything that is in red, that it has a red asterisk by it, is filled in the box. Next slide. This is the second page of the online referral for BabyNet. This is the area of concern. It has a drop-down menu, and we usually choose diagnosis as a choice. Next, we describe the concern. For example, Down syndrome, born at 30 weeks, hypoplastic left heart. Next slide. This is page 3 of the online referral to BabyNet. The person who is making the referral will fill out this information, the relationship to the child. This is where we choose in the drop-down menu DHEC, and then we put our name, the person making the referral, along with our phone number and address, and the South Carolina Birth Defects email address. We get a kickback email from BabyNet that lets us know that they have received the referral that was submitted to BabyNet. Next slide. And I'm going to turn it back over to Vanita.
So thank you so much, Karen. So in addition to the referrals to early intervention, we also, since 2006, have been referring infants, actually all pregnancy outcomes. So all people impacted by pregnancy outcome, whether it's live-born, stillbirth, or a termination that has a neural tube defect. So we refer them to Greenwood Genetic Center for pregnancy, for counseling for future pregnancies and for the purpose of recurrence prevention and health promotion. And we do have a legal agreement with Greenwood Genetic Center to contact these families, also contact the providers, and invite women into a very comprehensive program that helps to prevent isolated neural tube defects. Next slide, please. And this is Ms. Tara Carroll, my colleague who leads the South Carolina's EHDI program, will be the next presenter.
Okay, thank you, Vanita. Thank you, everyone that's here today. As they've mentioned, my name is Tara Carroll. I am the program manager for First Sound, which is South Carolina's Early Hearing Detection and Intervention, otherwise also known as EHDI program. And I am an audiologist by background. If you would go to the next slide, please. So the First Sound program, we've been talking about conditions that we screen infants for at birth, and congenital hearing loss is one of those things. And it happens to also be one of the most prevalent conditions. Approximately 3 of every 1,000 babies born each year have some degree of hearing loss, ranging from mild to profound, one or both ears, permanent or transient, with the majority being permanent. South Carolina is one of 48 states that has legislation requiring screening for hearing loss of all babies born in their states, and states without legislation have active programs as well. So it's getting done all across the country. Our legislation outlines what should be afforded to South Carolina infants. Screening should be done on all babies prior to discharge. Babies born outside of the hospital are to be provided information on how to get the infant's hearing screened, and some birthing centers actually do the screenings themselves, which is a more recent development here in South Carolina, one of which was prompted by COVID, actually. We also monitor for risk factors that may be present for late onset or progressive hearing loss, even if the baby passes their initial screening. The program also engages in follow-up, where the staff ensures that other parts of the legislation are met, and that those who did not pass their screening or who pass and have those risk factors receive follow-up screening and or diagnostic evaluation by an audiologist. We also notify primary care physicians for conditions that might require medical intervention as well, such as in the cases of transient hearing loss. When a baby is reported to have been identified with a confirmed hearing loss, then they're to be referred to BabyNet, which has been mentioned before is South Carolina's Part C Early Intervention Services. Equally important in all of the other stuff that's covered in the legislation, the things that families should receive, or the journey that should be taken, is reporting. We can't do any of this stuff without the information. So we can make sure that any of these services are received by the families. Hospitals report the screening results and any follow-up appointments if appropriate. Audiologists report their results of either rescreening or diagnostics. And early intervention shares whether or not those who were referred are actually receiving services. Next slide, please. I mentioned about the risk factors that we monitor for, and this is a tiered system that we use depending on the risk factor and when the follow-up screening should take place. But you'll notice that some of the items on this risk factor list are things that the birth defects program is specifically looking for as well. Next slide, please. Okay, so we have a lot of partners that we work with. For our staff, we're only 3 people strong in a centrally located office, and we have other DHEC programs that we work with. So our children and youth with special health care needs, we work with their central office staff, but their region staff helps us do kind of a boots on the ground in the respective regions to conduct some follow up for us for those that miss appointments or didn't get an appointment that might be heading in the direction of being lost to follow up. So they help us to that more local outreach to families. And then we work with our newborn screening program, the birth defects program. We work with birth facilities, that's hospitals and birthing centers. We work with audiologists all over the state. We work with BabyNet. And we also work with the South Carolina School for the Deaf and Blind. They have an outreach early intervention program as part of the school, and they actually fall under the umbrella of BabyNet for early intervention services. And any child that gets referred with a sensory concern, be it vision or hearing, automatically gets filtered to the School for the Deaf and Blind for their expertise in providing early intervention. And then we also work with a number of family support organizations trying to get families who have children identified connected with organizations that specify in family support for deaf and hard of hearing, because they do have some unique needs that need to be provide guidance and help families, because most families who have a baby that's born with hearing loss, it's their first, they're hearing parents, and then oftentimes it's their first encounter with hearing loss or deafness. So there's a lot to be learned for those families as they embark on that journey. Next slide, please. Just a little bit of data real quick for our program. So the chart on the right, on the left, is our screening rate. And you can see that we hold pretty steady around 97, 98%. And that's been basically since the program started. So like I said, it's getting done. We're not at the 100%, mostly because of the babies that are born outside of the hospital, but all of our hospitals are doing a top-notch job doing their screening and getting that information to us. The chart on the right is the rate at which we identify children with hearing loss by the 3-month benchmark that is a goal for EHDI programs. So, it's not a little bit farther away from the 100% that the benchmark is, but it is higher than the national average of 60%. And it is better than we have done in the past. So we have been working hard to close that gap for meeting that benchmark. And we still have some work to do. Next slide, please. Okay, on the chart on the left, it pertains to early intervention, and that shows the ones that the babies who have permanent hearing loss, the percentage of those that were referred to BabyNet, the percentage of them that actually were enrolled in BabyNet to receive services as compared to those who are receiving services by the time they were 6 months of age, because that 6 months target is also one of the goals of EHDI programs for early intervention. So we have even more work to do for improving those numbers. While we are higher than the national average, we still need to chip away at getting those babies enrolled. As Karen had mentioned earlier about making those referrals, even if they've had one made already, to kind of be a backup or a safety net to catch those that fall through the cracks. And then that's absolutely correct, because in a deep dive that I have done in our early intervention information, it's very clear that it takes a lot of families several referrals to actually make the connection and get enrolled. So they are closed out either for parent decline, or they can't get in touch with the parent, or there's just a lot of reasons, but those two are the top reasons that I've seen of why children haven't gotten their services, and they've been referred and re-referred sometimes 4 and 5 times before it actually sticks and they get enrolled. So duplicate referrals are actually a necessity to make sure that they get in to get the service, and that is a big factor to contribute why we aren't meeting that 6-month benchmark, is because if you have to refer somebody 4 and 5 times before they make the connection, then you're chipping away at that valuable time for that critical period that you're trying to get them in. And then on the right there is just a demonstration of the distribution of the number of hearing losses that we've identified over the past few years, transient versus permanent, where clearly the permanent ones are more prevalent than the transient. Okay, next slide, please. Okay. So in working with the South Carolina Birth Defects Program, I had a great relationship with Vanita. We talked frequently, and we actually, because we share a data system, the First Sound data collection system is housed in the same B data system that they are, separate modules, and unfortunately they don't talk to each other. So we would have to share data the old-fashioned way. So we had, in talking with each other, we came up with an idea where I provided a list of hearing loss related codes to the Birth Defects Program, and the abstractors, if they come across those codes, they document them in a spreadsheet that's housed on a secure drive that the Birth Defects Program staff and the First Sound staff have access to. And they give us the name, date of birth, and which code that they came across, and where hospital or place that they were, the chart was. And then that we compare that with who we have documented in our system. And if it's not someone that we have documented, then that information gives us leads to search and find some more information to see if we can confirm that this is a diagnosis and get all the information that we need to document and make sure that service is received. And then recently, we also devised a plan where we would provide a list of babies that have been identified to have risk factors and which risk factor they have. And so I dropped those into that into a spreadsheet on that same drive for them to look through and compare to see if they've missed anybody that might need to that has a birth defect that they're actively seeking to make the referrals to BabyNet. Unlike Vanita's legislation that expressly authorizes them to make referrals directly to BabyNet, ours does not. So that's another way that this sharing of information can kind of help circumvent that barrier for us so that we can let them know who has the hearing losses, and they can make those referrals on our behalf since they have the authority to do so. And my very rudimentary effort of making a pizza image here on my screen is I just kind of look at things where data collection for us is like slices of pizza. I'll take it from wherever I can get it. And even if it's just the tiniest sliver of information, like I consider that a lead, and we just kind of jump into Sherlock Holmes mode and try and track down any information that we can get to close the loop on some of those babies that just to try and reduce the ones that end up being tagged as lost to follow-up. And so such that closes the gaps for both of our programs. And that's all I have. I think that.
Sorry, I'll try that again. Thank you, Tara. As Michelle mentioned, or as I mentioned earlier, and I don't know if I stopped. Am I still sharing? I think I am.
You are.
Good, thank you. We had a lot that was shared in a very short amount of time, and I put up some prompts, but I just kind of want to remind you of what my colleagues have shared with you. We have talked about collaboration and case finding and challenges. So how do we identify these kids? How do we make sure that they're referred for early intervention? How do we work together to do these things? It was important to us, and I hope if you didn't hear anything else from Dr. Leadham's presentation, persistence. And I should have put that up there in my list, but we want to use surveillance data for more than just reporting. We want to affect the life course of these children. And when she mentioned several times, everybody was against it, but we knew our law would let us do it, and we kept it on. I'd be fascinated to hear your stories about that. We wanted to tell the stories of these children and impact lives with our surveillance data, and we wanted to do innovative processes for early intervention referrals. So I'll leave this up until the AMCHP folks put up something that they have, and I'll turn it back over to Sabra, and you can begin leading the discussion.
Okay, well, thank you so much. I am going to ask you to stop sharing if you would, because we are going to thank you to that amazing overview of the programs in South Carolina. That was really impressive and robust. And I appreciate the kind of frankness about where your challenges have been, because again, I think we all know there are a lot of them in this space. And as several of even the speakers noted, operating under different regulation, and statutory authorities and permissions and MOUs and contracts and all of that stuff that we know that everybody is navigating, in addition to the complexities of the work itself.